Okay, so it's your favorite Dr. Soloway here. Was inspired today while I was at a conference with a group of people, and a friend of mine who's a podiatrist asked me to give a talk on foot pain from the perspective of a rheumatologist. So I would look at foot pain in three ways. There's orthopedic foot pain, there's podiatric foot pain, and there's rheumatologic foot pain. Orthopedic and podiatric foot pain rely typically around injuries or deformities, needs for splints, bracing, and operations. When it comes to rheumatologic foot pain, several things come to mind. The first thing I want to point out is that all foot pain that occurs in a rheumatologic patient generally involves swelling, tenderness, warmth, and it can involve swelling, tenderness, warmth, or what is also known as inflammation in many parts or all of the foot. The tibial talar joint, which is the main ankle joint, can become very inflamed. It is famously inflamed in gout, as is the first toe or the big toe. When it involves the big toe, the generic word on the street is that it's called podagra. Podagra is just the definition of foot pain, so it's not literally translated into gout or something like that. In fact, an article from 1979 written by a colleague of mine named John Bomilowski and Ralph Schumacher, who is since deceased unfortunately, they wrote an article on the title being "Podagra is More Than Gout." And in this article they cited about 15 types of arthritis that presented in the big toe. Thus, we know many things occur just in the big toe alone. This can include osteoarthritis. However, it can include anything that occurs anywhere else. So a person can get an acute attack of Lyme arthritis, sarcoid arthritis, psoriasis arthritis, rheumatoid arthritis, gouty arthritis, calcium pyrophosphate arthritis, and a whole host of other types of arthritis. Again, the article was restricted to about 15 things that had been studied over a period of about 2 years, and they used all comers at the Philadelphia VA back in the late or mid-70s. Okay, so that said, one of the things as a rheumatologist that I look for is I look at the Achilles. I look at the Achilles insertion into the heel, or the calcaneus bone, the heel bone. The enthesis is a fibrous structure that connects the Achilles into the bone itself. When the enthesis is inflamed without trauma, this is sine qua non, or almost diagnostic of, what we call seronegative spondyloarthropathies, which includes psoriasis, psoriatic arthritis, Crohn's disease, ulcerative colitis, HLA-B27-related uveitis, sarcoidosis, and reactive arthritis, also known as Reiter syndrome. While I may have forgot one or two rare conditions such as Whipple's disease and possibly Behçet's disease, I think you get the picture. Another thing that you should think about when you think about feet, anything that can occur in the feet can occur in the hands. So if somebody has swollen hands and swollen feet, you just have to evaluate them as any other arthritic patient. So in terms of testing, everybody gets a chemistry and CBC, everyone gets urine, everyone gets rheumatoid factor, everyone gets ANA, everyone gets other testing to look for inflammation. I want to point out one thing as it came up today in conversation about ordering HLA-B27. I don't recommend ordering HLA-B27, and for the following reason. 10% of the population of the United States Caucasians are HLA-B27 positive and have no disease. And furthermore, this is something that is seen in various latitudes and longitudes. Sub-Saharan Africa does not have HLA-B27, and Eskimo tribes in the Arctic have almost 100% HLA-B27. So what is HLA-B27 used for? Well, it's a genetic marker, and in conditions such as ankylosing spondylitis, psoriasis, Crohn's, and the other things that I mentioned previously, if you have somebody who has sacroiliac disease and enthesitis, or in our case with the foot, the end of the Achilles, if the HLA-B27 happens to be positive, it is supportive evidence. However, supportive and diagnostic are very different. So you can have supportive evidence, not diagnostic. To order the test just because of foot pain, I think is a mistake, because when they come back positive, they create an unnecessary workup. What you have to do is have to have a clinical suspicion for inflammation in various areas called enthesis, occasionally a thickened Achilles tendon, In fact, Larry Bird's basketball career was ended because of psoriatic arthritis and recurrent Achilles tendonitis that was never diagnosed properly until he saw a rheumatologist. He had seen orthopedic and podiatry for years prior to the correct diagnosis being made. So also know that once in my career I saw somebody who came in for foot pain and rash and had a red nodule on their foot. So while this can give a broad-based or protean manifestation, in the case I'm referring to, the patient also had a fever and had endocarditis, and the lesion on their skin was a metastatic infection. That being said, people with endocarditis often break out in a rash. Some of the rashes that we see on feet, although I'm not a skin doctor, I do see a lot of feet. So you can get fungal rashes, or you can get psoriasis on the feet. There's actually a variety called palmar plantar psoriasis, often with pustules. They look more like pus balls than they do like scaly skin like people are accustomed to. There's plaque psoriasis, there's guttate psoriasis, there's another psoriasis, and for whatever reason I can never think of it when I'm giving these little videos. But the name at this moment doesn't matter. If I think of it, I'll pop it in. Plaque, guttate, and something else. Really bothering me that I can never think about what it is. So we do a lot of injections to the plantar fascia. Many people believe that they have heel spur pain. In fact, heel spurs don't hurt, and they probably involve half the population over 50 years old. But when somebody has pain in the heel, there's usually irritation of the tendon or the plantar fascia, which is actually a sheath covering that heel spur. And when that gets inflamed, since there's no good blood supply, you have to inject medication around that and kind of give it a bath. And that usually solves the problem, along with some cushions in the shoe, stretching techniques, usually to the thighs, and try to keep the tightness away. And then the hardest thing is to differentiate the mechanical heel spur causing stretching of the plantar fascia versus what's inflamed. So it gets back to basics. A very careful history involving everything, a very careful physical exam, appropriate lab data and appropriate explanations as to why tests are abnormal or normal, and then picking the proper treatment. I do refer to podiatrists, I do refer to orthopedic foot doctors. It really depends on the problem and my comfort level with that particular doctor. I hope this finds you well, and any questions or comments, let me know. Thank you.